Roopa Sethi. She is the program director for addiction psychiatry at the fellowship program here at KU. She's also the medical director of our opioid treatment program and just does fantastic work over there with the Suboxone services and is also an associate professor in psychiatry. So thank you, Dr. Sethi, for presenting today on this important topic. And we are recording the session, and there was information up at the beginning around CE credit. So if anyone has any questions around CE credit, they are with us in the chat. You're welcome to message them directly to make sure you have the information. And feel free to use the chat if you have questions for the presentation. We will get them worked into the discussion in this next hour. And I will turn it over to Dr. Sethi.
Thank you, Andrea, for the introduction. Good afternoon, everybody. I think this is a very important yet maybe underrepresented topic. And it is about more suicide, but I've also focused on majority of mental health disorders and substance use disorders together to make sure we understand why suicide can happen and happen more in this population. Okay, I have no conflict of interest. So what are our learning objectives? After attending this presentation, you should be able to articulate sources of data collected for substance use and mental health disorder, understand drug-induced mood disorders, understand the medications available to treat alcohol and drug use disorder, and outline which patient is more appropriate for which medication, and role of psychotherapy and programs, I'm emphasizing on that, and different programs in the dual diagnosis population. So I like to spend a minute on this because as we treat addiction and we take care of our patients with addiction, we forget what addiction is. At the end of the day, I want to remind everybody that it is a chronic, relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. And I think we think of the compulsive drug-seeking behavior that we see in our patients, but we don't compare it to other chronic diseases. Honestly, if you were to think of other diseases, maybe diabetes, for instance, it is a similar pattern. You know, the patients with diabetes tend to keep their blood sugars at a normal level. They try to maintain it, but at times they will have these very high blood sugars because they did not keep a regulation on their food or did not take their medications. So similarly, just to remind everybody, addiction is also a chronic and relapsing disorder. So if you remember this word relapsing disorder, you can take it home that, you know, relapse is a part of the picture in addiction. It will happen over and over again. And your role as a provider in any sort, so to whosoever is attending the session today, is to realize that it is the relapse is going to be part of the picture, and it is a chronic disorder. And our role is to help our patients get up and move so that they can stop that compulsive drug-seeking behavior. So it is considered a brain disorder because it involves functional changes to the brain circuits involved in reward, stress, and self-control. Okay, and then I like to talk about this a lot because I think this is the bigger picture that we all forget. I mean, how many times I have seen patients being admitted inpatient and, you know, I've heard them say, oh, I will just stop using, right? But it doesn't happen. Why is that? Because it's a bigger model. It's called the biopsychosocial model. That's true for all mental health disorders, but that is also true for addiction as well. So what is the biopsychosocial model, right? So if you break this word, the bio, the psycho, and the social model, right? So let's talk about the bio portion of the model. So the bio portion of the model is your genetic factors. So if you look at this slide, it could be what kind of genes do you have? What kind of opioid receptors are there? The dopaminergic tone in your body? What kind of neurotransmitters do you have? What is happening with the intracellular signals? And then don't forget that your genes are determined by your parents, siblings, right? So if you have, and that is why when we take history or we take detailed history, we talk to our patients about, do your parents or anybody in your family had problems with alcohol or drugs? Because that is very important to us. It tells us that this person is probably biologically predisposed to addiction if there is a family member, a grandfather or a father or a mother who was using drugs or alcohol in their life. So hence the biological portion of the addiction. There's also the psychosocial model. And what is the psychosocial model? It is really how you understand things, right? How you have grown up, how much stress has been in your life. What about the psychiatric disorders? And that is our presentation today, right? The substance use disorders along with mental health disorders, which increases rates of suicidality. And so if you have concomitant psychiatric disorders, that means your chances of getting addicted to drugs, using drugs, and using it as a self-medication model is going to be higher as compared to the general population. So another, the psychosocial model. And of course, the last portion of this model is the social model. So don't forget about family, friends, their living situation. So I'm going to give you an example. I have a patient who is really very motivated to get better, right? And she's on medications from us in the clinic. But she has this underlying depression and anxiety. And anxiety is so overwhelming that she just cannot function. As a result, even in the program, she continues to go to the street illicitly and get some benzodiazepines so that she can take care of her anxiety. Sometimes she's so anxious that she will end up using cocaine. And honestly, you should say to me, cocaine should make her anxious. Yes, of course. But, in that moment, it gives her so much energy that she feels better for a minute, right? So here is a model that I'm explaining to you, the psychological piece where she has this anxiety disorder and depression, which makes her use drugs. And what the last piece that I haven't told you is I recently met her husband, and I realized that the husband had a lot of control issues over the patient. And it was a very stressful life for her because at home, she's making sure the husband is taken care of. The husband tends to scold her a lot. You can say he's emotionally abusive to the patient. She has never mentioned to me that he's physically abusive, but the way the presentation in my office happens, I actually feel that the social piece, which is the husband, her living situation, is contributing for her to have that psychiatric piece, which is already there, but is getting exacerbated, and of course, making her use. So whenever you have a patient with addiction or mental health disorders, make sure you think of the biopsychosocial model. It is very easy for us to say, okay, I gave you the medications, now you should take care of yourself and not be using. But it is those pieces of the puzzle that those patients have to put together. They have to go home and make sure they're living in the same living environment. Some of their spouses might be using. Some of the spouses might be abusive. Some of them might have children at home that might be very disruptive. So there could be stressors at home, which could in fact lead to this whole model, and hence the susceptibility to both mental health disease and susceptibility to addiction. Okay, so I like to always talk about this, but when we give you all this data, and I will have a lot of slides with data in this because this is more of a data presentation, but I want to always talk about where did you get this data from? I always used to ask this question when I was in residency, where is this data from? So I want to tell you, and I broke it up into very easy distribution so that you guys can understand. There are two kinds of sources of data, honestly. There's the CDC, which is the Center of Disease Control, and the US government does not track death rates for every drug. However, there is a health statistics department at CDC that tracks most commonly used drugs. As a result, if somebody died from, for instance, a stimulant, I'm just giving an example, maybe it's not even tracked. But if somebody died of opiate or died of heroin use or fentanyl use, maybe it'll be tracked because that portion of that drug might be tracked. And then there's a CDC Wonder program, which is searchable data for public health systems. So this is just data that we collect about commonly used drugs. Now, there is a website, and if you guys don't know this website, it's super helpful for everybody. I think you should note down this name and probably look it up after the presentation. It's called SAMHSA. It's the full word for it is Substance Abuse and Mental Health Services Administration. And SAMHSA is a plethora of resources, and SAMHSA is where all our data, all my presentations, they come from. And SAMHSA collects a lot of data, and it actually has 5 points of data collection, which I really want to mention, and then it'll make a little sense. Where is this data coming from, right? One is the population data. That is what is happening in the population. They send out general questions or questionnaires, and then they collect data. So your prevalence of a disease, prevalence of drug use disorders, prevalence of mental health disorders comes from this population data, and we'll talk about it in a minute. Then there is the client level data. So if when I say the word client, if anybody gets admitted or discharged to a facility, then they collect that data. It's called the TEDS or the TEDS. There is also this emergency data, department data is also called the DAWN network. There is substance abuse facilities data. And then of course, there's the mental health facilities data. Now, giving you a little bit more about it. Sorry, it's a dry slide, but I think it'll give you more information of how we have all that we have. So I took a picture from the SAMHSA webpage, by the way. I took a clipping of it. So this is how the SAMHSA website looks like. But then it collects all these 5 kind of data. One is the population data, which is also called the National Survey on Drug Use and Health. So anybody who is a US civilian who is institutionalized population, so not in the hospital or hospital setting, 12 years and older, they collect data on it, and it's collected by the federal government, and approximately 67,000 people are interviewed by the National Survey on Drug Use and Health, which is also called NSDUH, every year. So that's how you get the prevalence data. Then there is the client level data, which I just said. There is one which is called TEDS, which is Treatment Episode Data Set. So what they really do is any admissions or any discharges to any treatment facilities in United States that happen, that will have to provide data to SAMHSA, and that's how they will know if somebody got admitted for maybe opioid withdrawal, or for a suicide, or for drug-induced mood disorder, or for dual diagnosis. They will collect it. Then there used to be a network, and it's still back. It's called the Emergency Department Data, which is called the Drug Abuse Warning Network. And what it really does is anybody who came to the emergency department. So for instance, a few days ago, I saw a 17-year-old patient in the emergency department who was there with opioid withdrawal and was really in like moderate to severe opioid withdrawal. So I'm assuming this data will then be collected by the DAWN at SAMHSA, and that's how they will know how many patients ended up in the ED with an opioid withdrawal or a suicide attempt. We had another patient that was admitted was seen in the ED. Well, she got admitted to the hospital. Was admitted in the ED because she overdosed on opiates in an attempt to kill herself. So there were 2 things going on. She overdosed on the opiate, and second attempt was to kill herself. So she also had access to these illicit opioids. So this data would also be collected by this DAWN network. It was discontinued in 2011, but has been restarted now. And then there is the substance abuse facilities data. So really, if you were to go to an inpatient program, if you go to any kind of substance abuse treatment service programs, then that data will also be collected by SAMHSA over there. And then finally, you will have the mental health facilities data that is also available. So any kind of mental health facility, if somebody is admitted, that will be collected. And that's how SAMHSA determines what is the rate of suicide, what is the rate of dual diagnosis population, what is the rate of substance use disorders among the United States population. Okay. So I just like to ask questions when I do slides. So just for this, you are seeing a patient for the first time and you suspect substance use and abuse. If you were to go to the SAMHSA website, which data set would you then utilize to find the prevalence of substances in this age and gender? I know I don't see the chat, and I don't know how many of you want to answer, but I'm gonna go ahead and give you the answer. So see, this is what I said. So this is how much of a prevalence of a substance. So it was not admission, it was not ED visit, it was not a visit to a visit to a substance abuse facility or a mental health facility. So this data will be collected by the National Survey on Drug Use and Health. Okay, so that's how you, these are the kind of questions people get, and this is how they collect the data. Another picture from, by the way, SAMHSA website, and you should see this website because it has a lot of information. Okay, so let's talk about co-occurring disorders. I'm going to give you two examples here, and both of them are my patients. And I think it will just, before I even talk about this slide, it'll give you a perspective on what we are talking about. So I just saw a patient a few days ago who was admitted for a pelvic inflammatory disease, and was given an opioid. And then when was given an opioid, had a side effect to the opioid. So basically overdosed on the opioid. So then they had to get the rapid response team, and naloxone was administered, which is an antidote to opioid overdose, and the patient woke up. Now, they were not sure why with one opioid this patient overdosed. And that was when our team was consulted. We also run an opioid use disorder consult team, and our team was consulted in the hospital. And when we went to see the patient, so this patient has been there for a day now, has not shared this information with anybody. And when I went to see this patient, and she knew I was an addiction psychiatrist, she broke up and she said, I really am very thankful, I need help, right? So for this patient who had not told anybody about a drug use disorder, then came up with a drug use disorder when she was admitted, or he was admitted for some other physical health or mental health disorder. So this is patient number one. So that is how I'm trying to link the two. So patient actually had substance use disorder, was using a lot of substances, had some medical and psychiatric complications related to substance use disorders, and got admitted not for substance use disorder, but got admitted for a medical problem. Okay, so that's your scenario number one. Second, I'm going to give you a scenario number two. This is my own patient in the clinic, and she has been a patient of mine for a couple of years. And we will talk about this later. Patient has a psychiatrist outpatient. We are dual diagnosis clinic, which means we can handle mental health disorders and substance use disorders over here. However, patient decided not to follow us for the substance use disorders, so for the mental health disorders, and we were only taking care of her opioid use disorder in the clinic. She was doing wonderfully with the opioid use disorder portion. We don't know what was happening with the mental health disorder. I was not allowed to communicate with the patient, which is a break in care. And then I heard that the patient got admitted to the hospital with a massive suicide attempt on the medication that was prescribed by us, and also by over-the-counter medication. So massive suicide attempt, had to be intubated, was in the hospital for days. So this is another patient that I want to mention. So patient has substance use disorder, but also has underlying mental health disorder that was not properly treated. She was very depressed, was not appropriately, at least now that she is back in the clinic, she tells us she was not appropriately treated and was not taking her medications okay. She was not feeling good, and she felt very depressed. And at that point, when she didn't know what to do, she wanted to end her life, she actually used the medications that were prescribed to her, and then over-the-counter medications, and overdosed. So having said that, that brings two things into perspective right there and then. So if somebody has a substance use disorder and somebody has a mental health disorder, their chances of having a suicide attempt or suicidality is going to be higher than that of the general population. So I made this table to just give you a perspective. So I say MDD stands for major depressive disorder, by the way. So if somebody has major depressive disorder, bipolar disorder, anxiety disorders, schizophrenia, personality disorders, ADHD, which is attention deficit hyperactivity disorder, PTSD, which is post-traumatic stress disorder, I'm sure you've heard these words, then their chances of using substances are higher than that of the general population, and vice versa, which I'm going to say now, the second part of the table. If somebody has opioid problems, alcohol problems, other drug use problems, then their chances of having mental health disorders is also going to be higher than that of the general population. Okay. So some of the facts that I just told you, I'm going to read it again. So compared to the general population, patients with mental health disorder, so maybe depression or anxiety, have higher prevalence of substance use disorder. So your question to me should be, if we were in a class, you should have asked, why is that so? Because maybe they are undertreated, or maybe they're not getting adequate treatment, or maybe they're not even getting treatment, and they then try to use substances and they feel better after use of substances. This kind of the self-medication hypothesis, and that they don't know when to stop. And then they develop a mental health disorder along with a substance use disorder, which is the whole concept of dual diagnosis. And then it puts them at higher risk of suicide because of the two together. Now, again, in the vice versa, compared to general population, patients with substance use disorder have higher prevalence of mental health disorder. So if you have a substance use disorder, then chances are that you could be also develop mental health disorders, and your chances are higher than that of the general population. Which is the most common mental health disorder which occurs with any substance use disorder is major depression. So if you have a patient with substance use disorder and they've stopped using substances, I would highly recommend you to go over different scales, or at least ask the patient if they're suffering from any depression or any mental health disorders. Similarly, if somebody has bipolar disorder, and we tend to forget this, we just treat the bipolar, it actually increases their likelihood to develop any kind of substance use disorder by 4-fold, which means they have a 4 times more chance of using substances than the general population. So if you have a patient who comes to you with bipolar disorder, if you see a patient with bipolar disorder, you must ask if they have any kind of substances that they use, because they might have underlying substance use disorder that we have never picked. Okay, most of the people know this fact, but patients with schizophrenia have a concomitant nicotine use disorder. Nicotine just works better in patients with schizophrenia. Their medications work better, they feel better, they are less clouded with nicotine, and nicotine use disorder is known to have very high prevalence in patients with schizophrenia. One of the highest personality disorders that you see with substance use disorder is antisocial personality disorder. I always like to talk to everybody about this, but when you are diagnosing somebody with antisocial personality disorder, make sure they're not actively using substances. Because when they're actively using substances and they're having symptoms and signs, or signs and symptoms related to the acute intoxication or withdrawal symptoms, then the personality disorder will not hold value. Then it is not a true personality disorder. I'm going to give you one example here. I have a patient with very severe alcohol use disorder, and she uses almost like used to use 4 pints of alcohol a day. 1 pint has about 17 drinks, so you can think of it maybe like 60 drinks a day. That a huge amount. Like, I had not heard of this much. And she then, when she came to our clinic for the first time, she was, throwing things. She was having a fit in the clinic. We had to call KUPD. And, I immediately saw an antisocial personality disorder in her chart. And that is fine. That got done there. But down the lane, it's about 5 or 6 months down the lane, she has cut down in a tremendous amount and drinks probably like maybe 4 drinks a day. And for this patient, I can just tell you that antisocial personality disorder does not hold true. She is a whole totally changed person. So yes, antisocial personality disorder is very high association with substance use disorder, but you got to make sure that the patient is not actively using when you give this diagnosis. Okay, so here is our big one, and this is the one that I really want to emphasize, is comorbid mental health disorder and substance use disorder is associated with very high risk of suicide. Okay, and this risk is especially very, very high in women. Okay, the risk of suicide increases about 11-fold in this population. Now I'm going to go back to my patient that I told you in the clinic. So we had the patient, reminding you, we had the patient in the clinic who was in treatment for substance use disorder for almost 3 years, was in remission, but had untreated depression and untreated mental health disorder, and went and home and overdosed on tons of medications, right? So remember, the risk of suicide increases about 11-fold in this population. So if you see a dual diagnosis patient, which is literally our entire clinic, then you want to make sure, and you'll see if you were to ever rotate with me, you would see that we always ask about depression and anxiety, and we give them scales. And I'm going to go over some of the scales as well. So here, I think this is a great slide, which tells you a lot of stuff, very, very important. So what is the population of people in the country where they get mental health services, but no substance use disorder services? It's about 55%. So 55% of the patients get mental health services, which is awesome. Then if you look at patients get no mental health services or no SUD services, it's about 34%. And then they get substance use disorder services, but no mental health services. And that is about 2% as well. And then you can see about less than 10% of the patients get treatment for mental health and SUD. So this portion is what I want to focus. And I know somebody raised their hand. I'm going to ask a question. 1 second, give me 1 second, but really want to emphasize on this, that about only less than 10% of the patients get treatment for both. So something like our clinic setting is so less available in the country. Even the fact that it is increasing, and this kind of clinics are increasing now, but only 9 to 10% of the population gets treatment for both in the same setting, or both, whether it's in the same setting or different setting, which is really, really a very small number. And that's why the high propensity of this population to overdose, or this population to attempt suicide. Andrew, can you see who has the question?
73.
So the question was regarding CE credit, so you are good to go.
Oh, okay.
But I'm forming a list of questions for you, so.
Okay. I mean, somebody has raised their hand, so I don't.
Oh, okay. I don't see the hand up, but go for it.
R55874. Okay. Okay, maybe it's a mistake. Okay. I'm going to move forward. So then it comes to this whole picture, right? What is the pieces of the puzzle? It's just not one piece. It's a lot of pieces of puzzle that we have to put together in this population. And more patients more and more people have gotten addicted in the last few years with pandemic. We have talked about it. I have a slide later that talks about it, more about numbers. But having said that, mental health conditions, especially when they're untreated, can increase the risk of developing SUD. We already talked about it. And think of this as the self-medication hypothesis. So they have mental health conditions that were not being treated appropriately, and then they are using substances, may it be cocaine, may it be Adderall, may it be benzodiazepines, may it be opiate for pain, to take care of themselves. And hence it can increase risk of developing the substance use disorder. So what are the challenges that you are going to see for this dual diagnosis population? One, it's mental health piece and the substance use disorder piece. So you are going to have a very complicated course. You will have relapses, either relapse to substance use or relapse to the mental health problems. So that's going to be part of your picture. They have increased suicidality. We talked about it, 11-fold increase in suicidality, and increased mortality from different reasons. They have unstable housing, and that is one of the bigger things. If you look at a lot of our patients in our addiction treatment center, and I can tell you stories about it, when they come to us, I actually will share a story of one of my patients who is an electrician now. And when he came to me maybe 5 or 6 years ago, he came from a good family, but his parents could not deal with him. He used cocaine and opiates. He overdosed about 2 or 3 times. But what was not diagnosed in this patient was he had an underlying bad depression. So when he came to us, he's got started on, buprenorphine. We started him on buprenorphine. He did well with the opioid treatment, but then cocaine, he could not give it up. Then we worked with him on a constant basis, got him a lot of therapy, got him into an inpatient program, and then the cocaine use stopped. But when both of them stopped, then I saw a very depressed patient. We did scales and he scored very high on these scales. So we started on antidepressants. So down the lane, almost think of it 4 or 5 months down the lane, we now stabilize this person who has both substance use disorder and a very big, moderate to severe mental health disorder. We stabilized him. But then what I found about his story is for last 6 months, because his parents had said, we don't want to deal with you, he had been living out of the car. So when he was living out of the car at night time, he was unsafe. Sometimes he was mugged. Sometimes people brought him drugs. So he always had this craving, all this craving available where he had access to all this stuff. So he had unstable housing and homelessness. Guess what? But if you give them stability in all these aspects, which, as a treatment center, we did, we had therapy available, we gave him meds, we treated his dual diagnosis, which is also his mental health, quite aggressively. Now, maybe 6 or 7 years down the lane, he went to school. He's become an electrician. He's not married, but he has a girlfriend. He just had a child, and he has a house where he lives. I mean, for that kind of portion, it took him that long of a time. And ask me if you want to, how many times did he relapse? Numerous times. So what do you do as a clinician? What do you do as a provider? What do you do as a physician? Whatever role you have with a patient like this, you help them move forward. You make sure you be a part of their recovery and understand it's a chronic relapsing disease and they can get better like this patient did over years, and then help them move forward. Okay, and then don't forget that also in this population, you see a lot of legal problems, DUIs, other drug charges. I have one patient that I see every day, very stable, young guy, but got into a lot of police issues. And he has 2 kind of ankle monitors on his legs. One ankle monitor on one leg and the second ankle monitor on second leg, because he got into 2 different problems with 2 different situations. And he walks with 2 ankle monitors on his legs. So you can think of how much, yes, they are helpful because he is not using, but it is also very degrading for him, as he says, because he says, I feel judged all the time. So I have to wear pants so that I can hide my ankle monitors as much as I can. And so it can have consequences. All these things can have consequences on our patients for moving them forward. Sometimes if you hear stories of some of these patients, a lot of them started at 14, 15, 16 years of age when they didn't even have insight. They didn't even had a full developed prefrontal cortex. And as a result, when they started, they lost everything to drug use. They couldn't even go to, schools, couldn't finish education. They lost contact with family. They burned a lot of bridges. They got into legal problems, and hence this whole complicated scenario that they have. Okay, so a question, that's a wake-up question. Patients with substance use disorder and mental illness, so both of them, have which of the following differences in outcomes compared to patients with only substance use disorder? Higher rate of response to treatment, less use of health services, lower rates of suicidal behavior, lower rates of side effects to medications, higher rates of mortality from unnatural causes. And I can't see the chat, so I guess I'll have to give you the answer. But I wish I had a polling somehow set up, but it has got a higher rate of mortality from unnatural causes. So because it's 2 diagnoses that you're dealing with, 2 diseases you're dealing with, this population has very high rate of mortality. And so hence we need to make sure we take care of them and make sure that we help them get better. Okay, so what screening tests do we do, for instance, in our clinic, or what screening tests you should know of? And it's difficult for me to cover it in one lecture, and I don't know where different people are in different levels of education, but I just want to throw out these names. Some of these scales are on the public domain. Good part is some of these scales are already on Epic. So if you go to doc flow sheets, you might be able to pick up some of these scales. So PHQ-9 is a scale that we use for depression. We use it all the time. We can just give it to the patient when they check into the appointment, and they answer questions for us, and it tells us if they're meeting criteria for depression. Super helpful. GAD-7 scale is a scale that we use for anxiety. Again, it's on the public domain. We print it out for the patient, we give it to the patient fills it, it tells us if they have any generalized anxiety disorder or any sort of anxiety disorders. We also have these others that we don't use as much: brief symptom inventory, back in anxiety inventory. You can use the Connors ADHD rating school, mostly used quite a few times used by schools as well. And you can also use the adult ADHD self-report scale, which I've used a couple of times with my patients. Honestly, about 10 years ago, when I just graduated out of my fellowship, I would say, if you have a drug addiction, I don't know if I want to treat your ADHD. But I have seen, as I have gone every day with my patients, that over time, to keep them functioning okay and for them to not relapse, if they have ADHD, you will have to treat it, because they become very dysfunctional with their ADHD symptoms. It makes them all over the place, and that is not a good thing for the patient, and that makes them relapse. So make sure that you also don't ignore ADHD. There's, of course, tons of other inventories that you can use. There's PTSD, there's other things, but I just wanted to throw out some screening forms and say, at least you should know the names of the basic scales and at least look at them and see how they work. Okay, this is a very interesting slide, and I think ASAM, so there are two models that teach addiction psychiatry. There's a ASAM and then there's the AAAP. ASAM is American Society of Addiction Medicine, and AAAP is American, Addiction Psychiatry Association, basically. And what we do is, the ASAM has built these criteria, which I think is wonderful, and it divides dimensions into the patient. And I think these dimensions really help, because if we can pick up all of these things, we can pick up suicidality in the patient. And ultimately, the goal of this presentation is, how can we help our patients get better with their mental health, so that we can help with suicidality in this dual diagnosis population, right? So they divided into 6 dimensions. And, I will tell you why these dimensions are important in the next slide. But dimension 1 is, what is their acute intoxication level? What is their withdrawal potential? So I'm going to give you an example. Patient comes in with alcohol. You do a blood alcohol level, and it is pretty high. You want to assess what this patient is going to look at. You start SIVA score, or AVA score, it was what we call it. And then you want to make sure you take care of their withdrawals and you take care of that patient right then. So that is your major drug use problem, right? Then dimension 2 is, you want to get their medical history, right? So look at my patient that I just told you of a few days ago, who was admitted. She came in with some kind of pelvic inflammatory disease. So we want to make sure we take the medical history and we treat the medical problem, because the substance use problem is not going to get better if we don't treat the medical problem. Dimension 3 that they use focuses more on the mental health and cognitive conditions. So I'm going to give you another example of one of my other patients. So is doing very well in the opioid treatment program, is on methadone, but had a few mini strokes a couple of years ago. So the medical portion of this dimension, but has developed cognitive issues with his speech, with his talking, and with understanding things, which makes it a whole separate level of how to take care of this patient. Hence, this dimension is very important. Of course, if they have mental health issues, this is where you want to get all that history. Then next dimension that they break it up is, what is their readiness to change? You might have all these problems. Okay, this is your substance use disorder level. This is your medical problems. This is your mental health problems. But then this patient might be looking at you and saying, I don't need you. I don't think I need you here. You may now leave, right? So that is a patient who's not ready for change. Can you help them? Yes. There are stages of change, which in lieu of time, I'm not going to discuss here, but they can be very pre-contemplative, which means they're not even aware of a problem. And then there's the final stage where they're active and they want to change and get into recovery, right? So you can help them move, but you should know where this patient is. I once was consulted on a inpatient, and I went into the room and I introduced myself and I said, I'm an addiction psychiatrist. She looked at me, she got very upset, and she said, you may now get out of here. Okay. that is great, because I at least know one thing: this patient is not ready for change. So you should know where in the readiness stage it is. What did I do? Did I leave? No, I did not leave. I actually said, I understand that I made you a little upset, and I understand that you are not expecting me here because I'm not major part of your treatment modality. But now that I'm here, can we just talk about what's going on? Like a very open-ended question. She did talk to me. We ended up talking for about 30 minutes. And just to make the story shorter, about 15 days later, she ended up in our clinic, made her appointment herself, and came to our clinic. That is why you want to know what their readiness is and work with them, even if they are not ready to make a change. Okay. And then the next dimension is whether they have relapsed or they continue to use, or they have a big potential for relapse, because that helps you determine what level of care you can place this patient in. And I in my next slide, I'll show you the levels of care, because that helps your patient not only get help with substance use, but also get help with mental health, and also prevents them from a suicidal attempt or a suicide. And then final dimension, which is dimension 6, is what is the recovering or living environment? You can do everything, right? As a physician, for instance, I can say, hey, I started you on maybe Suboxone for opioid use disorder. I'm going to treat your hypertension too. I'm going to give you a medication for that. I'm going to give you medications for depression and anxiety. And here you are, you're all set. But if this patient is homeless or is living in a situation which is not safe, none of this is going to work. Hence, the importance of all these dimensions, and these dimensions by ASM, I think, are phenomenal, because it helps us make a big model for this patient to not overdose, to not have a suicide attempt. Okay, so it's called the 4-quadrant model, and I'm not going to discuss this, but people fall in this model based on those dimensions. It can be high suicide, high substance use, low mental illness, or they can be high substance use and high mental illness. And based on where they fall on this quadrant, then you can tell them what to do next, which is this. So ASAM, again, which is American Society of Addiction Medicine, has determined these levels of care. I am not going to go into details, but I want to throw out these words because you might hear them. And these words might be helpful for you to help manage this patient, take a path which could help this patient get into one, recovery, get treatment for mental health, and make sure they don't overdose or they don't attempt suicide. So outpatient is something like my clinic, right? They come here, they just see the doctor, they see a nurse. It's like the level 1. Even before that, there's an early intervention, and it could be like a DUI program, right? That they don't get treatment typically there, so that doesn't work. Outpatient, they can get treatment. Then there is a word called intensive outpatient. You might have heard the word IOP, and it depends on different kinds of IOPs. Normally, IOPs can be a minimum of 9 hours per week for an adult, and it can go up to more, like 20.
Hello, I'm sorry, my system is not malfunctioning, so I had to hide here.
Sorry about that. But they can have intensive outpatient, which is what I was talking about, so 9 hours or more. And then if it doesn't work, you can send them to a partial hospitalization program. What is a partial hospitalization program? So they go to a clinic, for instance, from 9 in the morning, or a setting to 9 in the morning to about 3 p.m. in the evening. And they do groups there, they see a doctor there, they see nurse there, they do all pieces, and they do it for a month approximately. And what happens is, at the end of the day, they come back home and they sleep in their own bed. Pretty effective, but higher level of care as compared to the intensive outpatient. And then there can be clinically managed population, which are also called residential programs. And residential, as the word suggests, is a residence, right? So it's like 24-hour care. So if the patient stays there, doctor sees you, social worker sees you, counselor sees you, or different health professionals can see you. It can be 2 kinds. It could be either medically monitored or not medically monitored. The medically monitored will have a doctor and RN on site, whereas a residential program, which is non-medically monitored, will have no physician on site. And finally, you can have a setting of a hospital-based. For instance, if somebody is really not doing well, then if you send them to a Strawberry Hill hospital, or you send them to some other hospital, it's the medically managed intensive patient in a hospital-based setting. So why is this care important? As this little picture shows, you can go from outpatient to an intensive outpatient, to a partial hospitalization program, to a residential program, to a hospital-based setting program. And that is why it is so important to put all the pieces of this puzzle together so you can help this patient. Oftentimes, when we have not taken care of one portion of the two, when I say two, it means either substance use disorder or the suicidality or the mental health disorder, then we cannot get a hold of the entire picture and we end up losing our patients. Have I lost patients in my clinical practice? Yes, absolutely. I had a patient that I can tell you years ago when I just got out and was seeking treatment with me for only for only substance use disorder, was going to another doctor for mental health disorder. And at that time, facilities were not able to talk as much as we can now. And I was not able to communicate with the doctor. Got a prescription of a big dose of benzodiazepine from that doctor for anxiety, and then took all of that 30-day supply along with a lot of alcohol and overdosed and passed, And it was a setup to me where I thought of that, a big setback to me, where I thought, how could I have not communicated? What could we have done different in this patient's care? Maybe this patient needed one of these intensive managements, maybe needed a partial hospitalization program, maybe needed a monitored or an unmonitored residential program, but definitely not an outpatient program, because that did not work for the patient. Okay, this is the intervention slide. I'm not going to spend too much time on it. ASAM has this placement criteria that you can look at, and you can find it on the ASAM website as well. In lieu of time, I'm just going to move forward. So what are the models of treatment? And this is just to tell you what is the best. There's a single model where you treat just the primary psychiatric disorder or mental health disorder, and you think the SUD will itself stop, right? Does not work. Sequential model, treat each problem sequentially. I'll first treat the mental health problem, then I'll treat the substance use disorder. Does not work. Parallel model, treat both problems at different settings. Not the most effective model. If you can get them at one place and treat them at one place, that's perfect. And then the last one, which is the best one, is the integrated model. Just like, our clinic does it. We call it the dual diagnosis clinic. We treat their mental health disorders and the substance use disorder in the same setting. So what is portions of this integrated model? In this integrated model, it's just not pharmacotherapy. And, as much as I want to emphasize on this, I want to tell you that pharmacotherapy and psychotherapy go hand in hand. So if you are going to treat mental health patient, a patient who's suicidal, patient who's using substances, it is going to be a combination of pharmacotherapy and psychotherapy that is going to ultimately be effective in this patient population. This has come more to me with more experience of working over years and seeing how effective and powerful psychotherapy can be along with pharmacy or medications. Okay, so I want to talk about this for a minute, okay? I want to just tell you, how do we diagnose somebody with any drug or alcohol use disorder? And not that you guys are going to diagnose, but I think it's just a good way of knowing, because if the patient does not tell you truthfully, then you can have somebody with no use disorder criteria. But if you ask the questions right, you can actually get drug use disorder criteria correctly and diagnose the patient. So normally, how do I divide it? In my way of learning, there are 4 portions that I divide it into. The normal physiology of addiction. The normal physiology of addiction is, if I was to drink 2 wine glasses a day, over next few months, the 2 wine glasses don't work as much. I now start taking 3 or 4, and the 3 or 4 are working. That is tolerance. And it's normal physiology of drug use, okay? Now I was drinking 4, then I increased to 6, and then I realized this is too much, I need to stop. As soon as I stopped drinking those 6 glasses of wine,
The sound is malfunction.
Oh,
Okay,
Regina, did you have a question for the group or for Dr. Sethi?
Oh, no, I do not. I just
Oh,
have
okay.
sleeping issues.
Okay, I'm gonna go ahead and mute you.
Please, my
Yes.
piece is not working. I can mute it. I can do anything. And I went to the back of the building so I could
No
hear.
problem. No
It's still
problem.
loud.
And then what is the core problem of addiction? They continue to use despite having knowledge of the consequences. And then there is this internal preoccupations that we have. So a patient might be sitting and watching TV with the family, but thinking of, oh, I need to use a drug. I need to use. They have thought about it. Oh, Lord, I've used too much. I need to cut down. But they have unsuccessful efforts at cutting down. They're spending a lot of time either trying to get the drug, use the drug, or recover from the effects of the drug. And they have used larger amounts over longer period than they intended to use. And this all leads them to have external consequences, which means they give up important roles in their life. And they are, having social interpersonal problems. Their spouses are not happy, their bosses are not happy, they're not reaching work on time, and they have given up important activities of their life. For instance, not going to church, not going to get groceries. And as a result, they are, because of the social interpersonal problems, they're now using it in physically hazardous situations, for instance, driving after using drug or alcohol. And you only need to actually meet 2 criteria out of these 11 criteria to meet criteria for drug use disorder. But what I really want to emphasize in this slide is that if you give a patient this criteria, and if it's a pre-contemplative patient, might not get any positives. But if you ask them the questions right, you might get a few social criteria that might be positive, that might help you move forward with this patient. I'm going to omit this because we have a very few minutes. There are medications for alcohol use disorder, medications for opioid use disorder. They're all FDA approved. They work very highly. I can talk about it later. And I just want to emphasize on this slide. In United States, there was about 108,000 deaths in 2021 in the general population. And these were overdose related deaths, okay? And then among persons 14 to 18 years of age, overdose deaths increased 94% from 2019 to 2020 and 20% from 2020 to 21. What I really want to say, because these were overdose deaths, we really don't know if they were just overdose or was there suicide related to overdose. So again, widespread availability of illicitly manufactured fentanyl, we call it IMF, proliferation of counterfeit pills, which contains these IMF, and then these things are available on social media, has posed a very fatal overdose risk among adolescents and adults, okay? And so just know that it's there and the numbers are increasing every day. So we got to be very vigilant in helping in our population and making sure that we lower these rates. As I wanted to put these pictures. These are my patient fentanyl pictures, so not from the web. When I have patients, I tell them, if you have a good fentanyl picture, give it to me, because I want to know what is the trend these days. So why I put these pictures is, look at the second blue pills right here. One of all, my patient told me it's in this thing because there's an app on iPhone that you can put the pictures on that app and it'll actually count the number of pills for you. So for some of our patients who are dealers, they don't go and count like 10,000 pills. They just put it on the app and the app tells them the numbers. But I want to point out, look at the color of the pills, the 2 pills. These are both fentanyl, both different patients of mine. And this one has a deep blue color and this has a turquoise color to it. And then this, if you look and compare it to an oxycodone M30 pill or 30 milligram pill, it looks exactly the same. But this is a fentanyl containing pill. Nobody can tell. In fact, when I looked at this picture, I said, this looks like real oxycodone, but it is a illicitly manufactured fentanyl containing pill. And over time, my patients have started showing me this, which is, this is the kind of fentanyl now that's available on the market. And people snort it, smoke it, but this is very, very potent. And for somebody who has never tried fentanyl before, they can overdose and die within seconds. Again, how do people use it? They use it inhalational. They use it in Flonase bottles. They use it orally, powder, intravenously, and it's all over. And I just put these fentanyl facts in because that's what is affecting a lot of our population in the substance use disorder world. In fact, there was this new article on one of the news channels that said that, nowadays cocaine and methamphetamine is also being laced with fentanyl. I've had a few patients whose marijuana was laced with fentanyl. So really, we don't know what people are using. I tell my patients, if your source is not reliable, think it has fentanyl in it. Those are my references, and those are you probably, if somebody has seen us, we have the McNally Addiction Treatment Center. This is some of our staff on last Christmas Eve. And then this is the faculty in the Addiction Treatment Center. And this is one of our fellows who's now actually an attending, and she did a poster at AAAP. And then this is the Strawberry Hill Hospital. Just wanted to give you an idea where we work. We work in the Olathe building, and I'm open to questions.
While we're waiting for folks to come up with their questions, feel free to raise your hand or come off mute or put it in the chat, whatever works. I think one thing that struck me, and just from work that I've been doing in my research, is at the beginning, you talked about how those people that maybe don't have access to adequate health care, et cetera, this may be chosen as their easier point of entry for, reducing symptoms of depression or anxiety. So I think that just hits on the social determinants of health, of like, for those that can't afford healthcare, don't have insurance, don't have a close point of contact to get those sorts of resources. For them, street drugs, marijuana, all of those things, alcohol, that may be the only source of relief for them, not realizing how the further on down the road piece is. So I appreciate you bringing that out.
Right. And, we will have a lot of our patients tell us that they started using marijuana at age 14. And if you ask them why, I just used it with a friend, I felt better. What I don't know is, why did you feel better? Was there underlying anxiety, underlying depression that it treated for a little while, and then you used it daily because it made you feel better than what you felt before that? However, you didn't seek any treatment with psychiatry or with even some of them don't even have primary care treatment. And that is why this became a chronic problem. And over years, there is a cross addiction that always develops to maybe alcohol and then opiates. And then we have a plethora of drugs that are playing role in when actually it was mental health disorder at baseline.
And then the other thing I was thinking about, again, I've got lots of questions, so if anybody else wants to interrupt, please do. The other thing I was thinking about was the misadventure, death by misadventure, because there are so many instances of like, how do we categorize somebody who got like a terminal notification of liver disease, and so then they just decide, well, I'm not even going to try to get sober or anything because, it's not going to change anything. So just, drinking themselves to death accidentally, intentionally, on purpose, all of those things. Like, I just think that that's such a hard to categorize, the death by misadventure kind of category.
And, we get a lot of these patients. Interestingly enough, I have found that after some of them have received diagnosis, they actually end up coming to the addiction treatment center, and they actually want to get help, and they actually want to get themselves on medications so that they can get treatment further. A lot of them are refused treatments because, if you're actively drinking or actively using drugs, then there is limited chances and scope of treatment for a fatal condition that this patient might have. So one of the other factors drives the other one, but they sometimes will come and seek treatment.
We just got a question in the chat. Can you speak about your perspective on marijuana becoming legalized in many states in the nation? Is there a correlation in those changes in the OD suicide rates in the last few years?
So marijuana is a whole topic in itself, but this is what I tell our patients. I say, if you have a substance use disorder then your chances of getting addicted to marijuana is going to be higher than that of the general population. If you have a mental health disorder, then your chances of the marijuana being your relief source is going to be higher. And we don't know if marijuana is really going to treat the mental health disorder, maybe depression or anxiety, or it's going to worsen the mental health disorder. Having said that, the second thing I always talk about, in 1960s, the marijuana that was there had a potency about 20 to 30%, or the one that was smoked. Over years, the THC content in this marijuana has gone up so much that their potency has increased about to 60 to 70%. So we are looking at a more potent form of use. And we are also looking at younger and younger population who's now using marijuana thinking it's legal, but they're also using a very potent form of cannabis, which can actually cause cannabis-induced mood disorders, including cannabis-induced psychotic disorders. I have had a couple of patients in practice who've come to us with cannabis-induced psychotic disorders. One other form of cannabis that is pretty prevalent is called wax. And, it looks like wax. It goes in a little bottle and it can be stored there. And there's a newer form of cannabis that's now available, which is called rosin. And you can buy that device on Amazon and literally use that device to make rosin press. And you can just keep it in a little lens solution bottle, but people dab on it. They call it dabbing, and they dab on it. The problem is the potency of that cannabis is about 90%. So if you don't know what you're using and you use too much, you are going to have side effects to use of these drugs.
Melanie says, thank you for explaining the complexities, lots of valuable information. Another question that I wanted to check in, or maybe this is just from my own personal experience with addiction and recovery, is that you spoke about it's not just during the addiction period where people have their, those mental health disorders pop up. But I think a lot of times people that are on the other side recovering, now that they finally stopped putting some things into their body and they're working on recovery, those things that they have been treating with drugs and alcohol start to flare up. And so therefore that it's just as important to continue that mental health support after to prevent a bad outcome, because a lot of the times that's when you start dealing with the depression, anxiety, PTSD, whatever.
Absolutely. And I think that is such a very valuable point and very powerful point that you said, because yes, when the drugs are going to be out, the mental health symptoms will have an exacerbation because you were self-treating, the self-hypothesis, self-medication hypothesis. But that is why it is so important for an integrated program where you can check, like for instance us, where we can check on the patient and make sure that they're using, they're taking medications or making sure they're not very depressed. Just like I explained the case of my patient who was in recovery for 3 or 4 years, but ended up with a massive suicide attempt. Honestly, we did not think she would make it. It was such a massive attempt. And, now that she's out of it and her depression is better and I see her, all I see is that she is so remorseful of what she did, but she talks about how depressed she felt and how she was not being treated appropriately with medications. So yes, it is very important for people to realize that even if this substance has gone away from the system, remember depression is again a chronic, relapsing and remitting disease. So you're going to have, yes, normal periods where you feel normal, but then you will have these sudden, relapses where you will be very depressed and you need to take action during that period. You need to voice it to your psychiatrist or to voice it to your primary care or somebody so that you can get help. And there are so many treatment modalities that are available for depression, just not medications. We have the ketamine treatment now, we have TMS treatment, and of course the gold standard ECT treatment. Have I done ECT treatment in patients with dual diagnosis? Yes. And I've had 2 or 3 patients I've done it in, and it has worked wonderfully in the patients in resetting them and helping them come to baseline.
And we are at 1:05. That was a fast hour. Holly Fisher says, excellent presentation. Thanks for the work you're doing in the clinic. I don't know if there's any other questions before we wrap up, but thank you, Dr. Sethi, for this incredible presentation. The CE information has been posted in the chat. We'll keep this open for a little bit more for people that need to grab it. Thank you again, Dr. Sethi.
Thank you. Thank you for having me.